Ancient works dating as far back as 3500 BC invoke images of spinal deformity and the unfortunate burden borne by these severely disfigured individuals. In approximately year 460 BC, Hippocrates prescribed scoliosis with scientific prudence. He recommended treatment with an extension apparatus called the Hippocratic ladder, requiring suspension of patients in an inverted position for axial distraction. Centuries later, the Greek physician Galen began studying the subject with cadaveric dissections, and in his volume on the usefulness of parts of the body advanced our understanding of anatomical structures. Little progress was made during the Dark Ages until mid-16th century. France, Ambroise Paré recognized the progressive nature of adolescent spinal deformity and advocated its treatment with bracing. Other notable developments in brace treatment made in the 20th century include the Milwaukee brace, originally designed by Drs. Blount and Schmidt for post-op care. It was used to help control scoliosis in a growing child until the child decided growth to undergo fusion. It was observed that some children actually improved their scoliosis and no longer needed surgery. The brace was then used to prevent progression of scoliosis. The riser local cast was introduced in the 1950s. Joseph Reiser also designed the riser sign, iliac crest, and skeletal maturity. Pioneering surgical treatment from the early 1900s stemmed from the treatment of patients with tuberculosis and pot disease. Russell Hibbs introduced the concept of fusion for scoliosis in a landmark publication in 1924 for 59 patients. The goal was to maintain rather than correct the scoliosis. A few decades later, in Houston, Texas, Dr. Paul Harrington began working on instrumentation for post-polio scoliosis, an epidemic peaking in the 1950s. He first attempted operative correction with transfacet screws, but failed. In the next several years, he developed a new approach using hooks and threaded rods, initially instrumenting the convexity, but then adding a distraction system on the concavity. Although Dr. Harrington originally conceived of his operation as a dynamic one, he ultimately realized that fusion was required in addition to instrumentation to achieve lasting correction of the deformity. One such complication of the Harrington distraction instrumentation was development of flat back deformity. This was due to the kyphogenic nature of the distraction instrumentation. Nonetheless, the wide acceptance of Harrington's operation paved the way for future development and methods of internal fixation to correct spinal deformity. Further evolution of spinal deformity surgery continued with the goal of reducing post-op bracing and immobilization, with contributions from Dwyer and colleagues utilizing an anterior approach in segmentation. Dwyer and colleagues used titanium screws in the vertebral bodies connected with threaded cables that could afford correction over a few fixed segments, but risked development of lumbar kyphosis and flat back deformity, similar to the complication from Harrington distraction instrumentation. Their technique was modified with a threaded rod, which was popular for anterior correction of scoliosis from the 1970s to the turn of the century. Luke instrumentation and posterior segmental fixation is another pioneering development. Dr. Luke popularized segmental fixation utilizing sublingual wires connected to L-shaped rods on each side of posterior elements, but passing wires is concerning for neurological complications. Modification of this technique utilized Harrington rods combined with segmental Luke wires. The dawn of modern spinal instrumentation is attributed to Cottrell and Dubussé. As first reported in 1988, their instrumentation revolutionized treatment and allowed for increased stability afforded multiple hooks placed at strategic locations on both sides of the spine, connected by curled rods placed bilaterally, cross links for transverse traction. The construct obviated the need for post-op bracing, and the corrective maneuvers such as rod rotation showed unparalleled deformity correction. This quickly became the standard. Ultimately, pedicle screws replaced hook implants for their three-column purchase of the vertebra, affording more segmental stability and deformity correction. Today, this particular instrumentation with bilateral rods or even multi-rod constructs are commonly performed.